So one of the biggest, questions I get when we're talking about using ultrasound as your imaging prior to doing a rotator cuff repair is, can you assess atrophy and reparability of the tendon? And the answer to that is absolutely yes, you can. So I just want to do a quick video and show you some of the things that I've learned to help me kind of in a decision-making process of whether or not this is a tear that could possibly be one that we could not fix, or that would be a high risk of failing even if you did repair it. So starting off in the front of the shoulder, standard ultrasound exam. So like always, first thing we find is the biceps groove in the front of the shoulder. Now the next thing you look at is the subscapularis. So subscapularis tears, small tears are difficult to find even on MRI, but when you see a large subscapularis tear on ultrasound, and by large I mean you see no tendon interface with the tuberosity, and when you internally and externally rotate the shoulder, you're not seeing any tendon associated with it, that's a high grade subscapularis tear. That's going to be one that's retracted significantly medially and one that's at risk for not being able to be fixed or high risk of failure. So whatever decision making you need to do to deal with that, that's what I would do. But basically with the subscapularis in particular, if you see no tendon interfacing with the tuberosity at all, that's going to be a very high grade retracted subscapularis tear. Now the next thing we look at is the supraspinatus and the infraspinatus, and so there's a couple of simple tricks that I found to help me with this. Is we get our standard view, modified Kruse position right here, probe on the tip of the shoulder, so we're looking at the leading edge of the supraspinatus. So when you scroll back and forth looking at supraspinatus and infraspinatus, if you can see the edge of the tendon lateral to the acromion, here's the acromion right here, here's the edge of the supraspinatus, if you can see the edge of the tendon, this is a repairable tear. It's a repairable tear 100% of the time. If you cannot see the edge of the tendon, meaning that it's retracted medial to the acromion, that's a tear that's possibly at risk. So if you see the edge of the tendon throughout looking at the top of the shoulder, your long acus supraspinatus tear, I'll repeat that again, that is a repairable tear 100% of the time because it's just not a retracted tendon. If you cannot see any portion of the rotator cuff tear or any portion of the tendon edge medial to the acromion, that means it's retracted, and it's difficult to assess how much it's retracted at the level of the acromion because the acromion blocks you. All right, so that's the next step. And then looking in the back of the shoulder, when we look in the very, very back of the shoulder, go a little bit deeper here. You're looking at the, right here when you go just underneath the acromion, what you're really looking at is kind of the mid portion of the infraspinatus. If you're internally and externally rotating the shoulder and you see no tendon interfacing with the tuberosity there, that's a massive posterior rotator cuff tear, so that's a very large tear. When you come down, the teres minor, the muscle belly is a little bit shorter. A teres minor tear is extremely rare. I've seen just a handful in doing a couple thousand of these exams. So teres minor is very rare. If it's torn, then you obviously have a massive tear as well. So let's say hypothetically, let me get this undone from here. Let's say hypothetically you were ultrasounding the patient's shoulder and you see when you're looking at the supraspinatus and infraspinatus long axis, you can't see the tendon edge. So you say, okay, we're dealing with a massive tear. Well, the next step is then to look at the muscle bellies, right? So people ask, can you quantify atrophy on ultrasound? The answer is absolutely yes. So the first thing I look at, maybe scoot this a little bit, there you go, thank you. The first thing we look at is infraspinatus and teres minor muscle bellies posteriorly. So if we're coming here, right here, we can flip the other way. So what you want to find is the scapular spine right here, which is up there, and then you're going to look right here is the infraspinatus muscle belly, and then right here is the teres minor muscle belly. And what you really are trying to do is get a comparison view. So you see, obviously in Shandy here, that there's no difference in the quality of the muscle bellies. If you have a retracted infraspinatus tear, this will be atrophied and this will be hypertrophied. This will be hyperechoic, i.e. fatty atrophy because there's less water, more fat. This will be hypoechoic, and you'll lose the kind of the pennate muscle belly structure of the infraspinatus. So it's the same exact view that you get on the MRI. You're just using ultrasound to get it. So here's the scapular spine. You're looking at the short axis infraspinatus muscle belly, and you're comparing it to teres minor. So that's the first step, and that's how you're quantifying infraspinatus atrophy. The next step is to look at supraspinatus atrophy, and there's a couple different ways that you can do that. The first way that I like to assess it is coming into the supraspinatus right here, and we're looking at it in the long axis. Okay, so right here is medial, here is lateral, And right here is kind of where your divisor's portal is, so it's where the acromion's kind of coming forward and meeting the AC joint right there. So you find this muscle belly right here, and you're just looking at the difference in the muscle bellies first. Just look at the pennate structure, see, and here they're almost exactly the same. They're the same quality muscle, everything looks the same. If there's a retracted tear, it's going to be hypertrophied, it's going to be atrophied, it's going to be brighter than the muscle belly up here. And this is a great test. Dean Ziegler showed me this. And so the next thing I do is I have the patient push her elbow, push, and then relax, and then push again. And what we're looking for here is the contractility of the muscle belly. Now with hers contracts some, but she still has an attached tendon, so it's not going to come back that much because it's isometric. If someone has a tear, and it's an acute tear or a tear that still has a high quality muscle belly, you will really see that tendon retract, and you will see this muscle belly thicken substantially. If someone has an atrophied retracted tear, there's no contractility left in the muscle belly, and it's going to be one of those tears where you go in, you do all releases, and you pull down, and there's a tremendous amount of tension on that tendon, and it's because the muscle belly has been shortened for so long. So this is a phenomenal test, something that you cannot do on MRI. So you just hold your hand right here and have them do an isometric contraction. And the hard thing with ultrasound is the probe wants to move. So what I tell you is push against me 2 pounds, just 2 pounds. Just relax, just 2 pounds, there you go. So just a light contraction is all you need. And then the next thing to look at is your Y view. So just like your Y that you're gonna get when you look at your deep MRI view, so this is like a sagittal MRI. Let me get this flipped. So right here is your clavicle, here's your acromial spine, and then you come deep and you find the muscle belly right there, and you're looking at the level of retraction there, and you can again do the contraction test here. I like it the long axis more that way, but this is really just looking at that short axis view of your supraspinatus and looking at the quality of the muscle belly compared to the trapezius that's overlying it. So here you see it's a little bit different muscle quality, but still she's got a nice large supraspinatus. It's not, there's no tangent sign here where you would come across and look and see, how much is the level of the supraspinatus muscle belly inferior to the Y view there, but that looks great, so there's nothing there. So definitely some ways that you can quantify atrophy with ultrasound. No question that and this has all been studied and looked at, and the inter-observer and intra-observer reliability is just as high as looking at MRI with the Goutallier classification. So it takes a little bit of time to learn how to do these things, but I think looking at those with ultrasound, I get the same exact information that I get from an MRI, trying to make a decision in my mind, is this a repairable tear or is this a tear that's at high risk of failure?